Hello, and welcome to our next session on our series of webinars on emergency health workforce policies to address COVID-19. My name is Sarah Westergaard, and I am a postdoctoral research fellow at the Fitzhugh Mullen Institute for Health Workforce Equity at George Washington University. I will be your moderator of today's session on mobilizing health profession students. As cases of COVID-19 continue to increase across the U.S., the increased demand is placing a strain on the current health workforce. It's also interrupting the education of current health profession students and has brought clinical rotations almost to a halt for many students. This is due to a number of factors, including concerns regarding insufficient personal protective equipment, as well as the need for social distancing. We don't know how long this pandemic is going to last, but maintaining the educational pipeline is essential to ensure that we have an adequate supply of appropriately trained health workers in the future. It also begs the question, what can health professions students be doing now to respond to the COVID-19 pandemic? As states across the country are developing and implementing policies to address the increased need for health profession students, many leaders are looking at health profession students to step up to this increased need in capacity. In today's webinar, we will talk a little bit more about how students can help respond in this setting, and particularly those who are close to graduation, how they can be mobilized. We are fortunate today to be joined by two experts who are working at the intersection of education and health workforce, and who have been actively engaged in the mobilization of students during this pandemic. Dr. Garrett Chan is the president and CEO of HealthImpact, California's nursing workforce and policy center. Dr. Chan is also an associate adjunct professor in the School of Nursing at the University of California, San Francisco, and is a practicing nurse practitioner at Stanford Healthcare. He has been an emergency nurse and a Red Cross disaster health nurse for over 20 years. So thank you, Garrett, for joining us. Our other guest is Jo Wiederhorn. She's the president of the Associated Medical Schools of New York. This body represents New York's 17 medical schools, providing advocacy and education on issues pertinent to medical education. As we know, New York State, and in particular, New York City's metropolitan area, has become the epicenter for the COVID-19 pandemic in the U.S. Jo and her team have been actively working with the New York State's Governor's Office, the State Board of Education, and the Liaison Committee on Medical Education to ensure students in their final year of medical school in New York are able to graduate early and that they're given the opportunity to practice during these extraordinary times. So, Jo, I'd like to begin with you. I know that nearly all medical schools in New York are graduating their fourth year medical students early so that they can potentially help out in this crisis. Can you talk about a little bit about how the decision to mobilize and engage medical students has evolved, or particularly fourth year medical students has evolved over these past few weeks in New York State?
It's a pleasure to be here. It all started a couple of weeks ago when the pandemic really started to hit in New York. And the Governor Cuomo at that time, started to call on resources, people who have retired, people who aren't necessarily working in hospitals to come and join the force in the hospitals to help care for COVID-19 patients. At that time, all of the medical schools, or practically all of the medical schools in the state, had stopped their classes. Students were learning via webinars and other forms of distance learning, except there were a lot of fourth year students or final year students who actually had completed all of their clinical work. And many times the schools were saying you should just go home because there's really no more coursework for you to do unless you've decided you want to do an extra sub-I or something along those lines. Around that time, I received an email from one of the deans saying that he had been thinking about using his fourth-year students in the hospitals and wanted to know what it would take to graduate them early. We brought in all the rest of the deans into the conversation. We brought in the deans for medical education. And at that time, not all of the schools wanted to do it. Only a small number of them, particularly those in New York City, wanted to do it. And we started talking about what it would take to do that. Well, the first thing that was needed was the LCME had to approve. And so I went to the LCME and they were really amazing. Within a day, I had a letter saying that as long as the schools met their basic requirements, they could graduate the students early. So what does that mean? It's 130 weeks of education, plus each of the schools had to put in their objectives for their competencies for their students and for their knowledge and skills. And as long as the schools could show that the students who they're graduating early had met the 130-week requirement, as well as had met all of the school's competencies that were required, the LCME was fine with them graduating early. At the same time, one of the schools was in discussions with the governor's office, and the governor said that, you know, the schools are thinking about doing this, and the governor's office became very excited about it. They thought this was wonderful. We need as many people as we can get. So now we were getting pressure from the governor's office to do this. And then NYU had a story in the New York Times saying that their students were going to do this. But they then got an email from the state education department. Now the state education department are the ones who issue licenses and who finally certify that the schools can exist in New York. And they generally do what the LCME, you know, as long as the school can pass LCME, then the school generally gets a stamp from the state education department. Well, this time it took a little bit of work. The education department wasn't that excited about graduating students early, didn't know whether or not this was the right thing to do. I sent them the letter from the LCME saying the LCME was fine with it. But it actually took some pressure from the governor's office in order for them to say, all right, we can do this. And so about 4 or 5 days later, the state education department issued a form, which is an attestation, which each one of the schools has to fill out, saying that they're meeting the LCME requirements for graduating their students early. And I thought, wow, that's great, success. We've done this now, right? Except then I get a call from one of the schools and they tell me that their attorney says that they can't place the students in the hospitals because the question arises, well, who are these students? What are they? What role are they going to play? They're newly graduated MDs. They're not in residency programs. Who's going to oversee them, and what is their title going to be, and how does this fit into their whole educational experience? And so we went through some time trying to figure out, well, what exactly are the roles of these students going to be? And how can we get them to be able to be in hospitals as physicians who can do physician work in the hospitals, of course in teams overseen by people, but they're not considered learners. So how do we go about doing this? In order to do that in New York, we needed an executive order from the governor saying that he was going to waive certain requirements in the education law and in the health law. So then we started doing that, working with the governor's office again, trying to get an executive order which actually came through just this past Saturday. But the ACGME has been issuing guidances about what students who graduate early can't do, shouldn't do. And so now we're running into the question of really putting down on paper, what is it that these students are going to do? And that's basically where we are right now.
Okay, great. Well, that kind of leads me into my next question, just about, what role will these, I guess they're not students anymore, they're newly minted physicians. So what role will these new graduates have? Will they be working, so they're not technically residents, so will they be employees of these hospital systems that are affiliated with the medical schools? And will they still be able to start their residencies on time in July?
Yes, actually, that's a good question, because that's what we're just figuring out. And actually, we have it figured out now. We finalized this at the end of last week. Each school, the newly graduated physicians are going to have a title at the hospital. So their title will be something along the lines of COVID-19 special physician or COVID-19 assistant physician. They will be placed in the hospital, usually in either the emergency department or in the medicine department, and they'll be part of a team. So they won't be off working on their own, but they'll be part of a team, and they'll be supervised by attending physicians. And this is really important. This was one of the issues that the ACGME had, because they didn't think that residents can be supervising physicians. They have to be supervising learners rather than working physicians. So they're considered physicians. They're hired by the hospital. They have the benefits of the hospital. They get paid, first of all. They have health insurance. They have liability insurance. The schools are generally putting them up in letting them stay in their housing so that they can stay there. And they are being considered as hospital employee physicians. Now, the issue is with the ACGME, what does this do to their residency? So they're going to stop being in this role of special physician anywhere from a month to 2 weeks prior to July 1st. At that point, if the student, or I guess student, is then going to a residency program out of state, they're going to have to quarantine because that's what New Yorkers have to do these days. So they'll have to quarantine for 2 weeks before they start their regular residency. They'll then go into their residency as PGY1s, interns, PGY1s, whichever. For those students who have matched to the hospital that is affiliated with their medical school, those students, really, it's much easier for those students. They're just going to stay right there as workers, not as learners, right up until July 1. And then on July 1, they'll start their residencies. So we think we have, we think we have it pretty well worked out and under control.
Okay, great. Just one other follow-up question. I know there are 17 medical schools in New York, including the metropolitan area as well as the upstate region. Mm-hmm. And as we've talked about, the outbreak is really focused in the metropolitan region. Are there variations between the medical schools and the hospital systems they're affiliated with in terms of, are they all doing this the same way, or is there any talk of any sort of partnership between some of these universities, sending upstate graduates to the metropolitan area?
So the virus has really hit hard in New York City, Westchester, and Long Island. The upstate schools, Albany, Buffalo, Rochester, Syracuse, they don't have the same kinds of restraints that the downstate schools have in terms of staffing and everything. What is happening is the schools that are, they don't even have to be upstate. Any of the schools, if I'm a student at the University at Rochester and I matched at a school in the city, or a hospital in the city at Columbia, the DIOs are then talking to the schools and saying, can your students start early? You know, can you send your student down here early? So that way, if the student wants to, and I think that's something that's really needs to be laid out here, this is all voluntary on the part of the students. Nobody is forcing the students to do this. If the whole class graduates early and some of the students don't want to do this, they don't have to. They have the benefit of having graduated early. So there's that kind of exchange, trying to get some of the students who have matched in New York to their New York hospitals so they can become adjusted and, you know, before their residency starts. Other than that, there really isn't that kind of an exchange.
Okay, great. I'd like to turn to Garrett now and talk a little bit about nursing. And so I know that nursing leaders across the U.S. have called for the mobilization and utilization of nursing students in the COVID-19 pandemic response. And as we see, healthcare systems and many communities are in dire need for health workers, or will become in dire need of health workers. And so just turning now, is there a role for nursing students in the response to COVID-19?
Yes, thank you, Sarah and Joe. It's been a pleasure to be asked to join this webinar. And I think one of the things that we need to remember about the concept of nursing is that the scope of practice, or actually more around the scopes of services that nursing has with the public, is that nurses work in the protection, promotion, and restoration of health and well-being, the prevention of illness and injury, and the alleviation of suffering in the care of individuals, families, groups, communities, and populations. So this is the definition of nursing and our social contract with America. And nursing's profession's roots lie really at the intersection of medicine and society. There are two major perspectives on what nursing is. One is that it's a holistic focus on patients, families, and communities in the context of social justice. And then another very common view of nursing is that there is a focus on the support roles within a defined set of clinical tasks in hospitals and other institutions. And so I think this is an important concept as we think about nursing students and how they can help in the COVID-19 response, because there are certain independent functions as defined by the American Nurses Association, as you see on the slide here. But then there are also interdependent functions of nursing practice on medicine, pharmacy, rehabilitation therapies, nutrition, psychology, public health, and among other disciplines. And so as we're thinking about how students are responding, or may be called up to respond and volunteer, to Joe's point earlier that all of this is voluntary, we're not mandating anybody to respond. We need to understand in the context of what nursing is and what nursing can offer in the COVID-19 pandemic, the services and the help to care for individual patients, families, community, and the public. We know that all levels of nursing students have the potential to help. From the very beginning phases of nursing education, we focus on social determinants of health and public health, patient and community education, as well as screening and testing. In non-COVID times, the screening and testing have been around disease entities like diabetes or people who might be at risk for high blood pressure or stroke. And so these screening and testing interventions can definitely be applied to COVID-19 when we look at perhaps drive-through testing centers and other mechanisms for us to understand the prevalence and who might be ill with COVID-19. Nursing leaders across the country are advocating for flexibility and creativity in meeting course objectives and student learning outcomes. And as you mentioned earlier, we do know that there is a displacement of students out of student housing as a result of COVID-19 and the physical distancing as opposed to social distancing. We don't want anybody to be socially distant from each other, but we do want people to be physically distant from each other. And we've heard that some students who had moved closer to their academic institution for education because of the closure of student housing have been forced to move usually back home or away from their academic institution. And so as we're thinking about mobilizing the nursing student workforce, we have to think about the impact on physical distancing and the movement of academic institutions to online learning. And if a student nurse wants to volunteer or be paid in their local community where they've landed away from their academic institution, we should think about that as well. One of the things that we're thinking about in California, is thinking about the concept of how nursing students can respond to varying levels of acuity in the COVID-19 pandemic. So in California, we've thought about 4 different levels of acuity. The lowest level being, of course, any kind of screening or testing centers or family, reunification centers where people are trying to get families connected with people maybe in the hospital. So student nurses can help assess patients, of course, by doing the screening tests and addressing any kind of psychosocial concerns that potential patients or the community have. This is definitely within the practice, and it doesn't require a ton of preparation to be able to help educate, especially with all of the information that we have available to ourselves as professionals around COVID-19. But also the concept of assessment of psychosocial concerns in this, what is generally known as social distancing, but what we're trying to call in California physical distancing is identifying any kind of psychiatric or psychological concerns that patients and the community might have. From that level of acuity, we have kind of what I would consider a low acuity level, which would be these alternative care settings, such as hotel cities. So the governor of California, Governor Newsom, has asked to try to stand up, if you will, 51,000 hotel and motel rooms to house low risk or low acuity patients to help them get better sooner. And so nursing students could work with on-site clinicians to help do assessments, educate, give psychosocial support, and again, infection prevention in these settings. The next level up is the moderate acuity patients. And so these would be patients who are in the hospital on a medical surgical unit, telemetry, or potentially even step-down unit. These patients, of course, need more medical and psychosocial interventions and the supervision of nursing students should be at a greater level because of the intensity of the interventions. So this is where we might see more senior nursing students be helpful in the COVID-19 response. In addition, though, there is more risk to the student because of the amount of COVID-19 that might be aerosolized in the hospital setting. And then the highest acuity, the fourth level of acuity, would be critical care. So more medical, psychosocial, and palliative care interventions might be required for these patients. Again, there's higher risk and a higher need for supervision for these nursing students. So that's how some of the things that we've been thinking about in terms of how nursing students can help respond to the COVID-19 pandemic.
Okay, great. Just thinking back to these opportunities for students, how is this actually playing out in terms of maintaining academic and practice partnerships for students moving forward so that we can ensure that the pipeline remains intact and the production of future healthcare workers continues? So would students get credit for this volunteering? Would they get paid? How would this work?
Great, thank you. If we go to the next slide, Sarah, some of the things that we have been thinking about specifically in California, but also I've been reading up on other states, is that the National Council of State Boards of Nursing monitors each state's waivers related to education and helping nurses enter the workforce. And one of the things that I've noticed in the National Council of State Boards of Nursing state-by-state evaluation is that a lot of first of all, they advocate for these academic and practice partnerships. They advocate that we should be flexible and innovative to figure out how to meet course objectives and student learning outcomes. What we're seeing in my analysis is that waivers across the states fall into three very broad categories. They are allowing more latitude on clinical experiences, increasing the amount of simulation, and suspending or creating new licensure requirements, similar to what Joe was talking about and what's happened in New York for medical students who now have become physicians. And so the waivers kind of across the states are really trying to help move the nursing students forward. And one of the things that, as we're looking at it in California, we've identified that there are 4 different kind of domains of work that we need to do in California. And we've had progress in varying levels in these 4 different domains. And the 4 domains really revolve around student preparation and education, helping the practice settings understand these nursing students and who they are and what they should be doing, kind of what Joe was mentioning. Also, there is a lot of faculty education and support that we've been providing and trying to figure out the pathways for faculty support. And then what are the statutory and regulatory issues that need to be addressed? Again, things that Joe had mentioned earlier. So I'm just going to run through these really quickly. So the student preparation and education. So we need to get the nursing students ready for an assignment. So they need to be educated specifically around COVID-19 and all the various levels of acuity, from prevention all the way to critical care, depending on where the nursing student will end up. We also want to match the abilities of the student that they have attained through their school education and achievement of their competencies, and being clear with the students that they need to share those competencies so that people will know what they've attained when they go to their clinical partnership. We also have created a risks and benefits, almost like an informed consent without having a signature or not really a legal document, but articulating the risk, benefits, burdens, and alternatives to responding to COVID-19. Again, recognizing that these are students and they are not necessarily aware, perhaps, of all of the various components of risk, benefits, burdens, and alternatives for responding in a disaster. So we want to be very clear and upfront with them. Preparation for assignment, like how do you get prepared? How, what do you bring? What kind of clothing, your medications, if you are taking medications. So some of the logistics, and we're looking to the Red Cross to help us with that because they have some really good guidance for people who might be going on assignment. And then documentation of any kind of clinical experience, because we're trying to, in California specifically, there are some statutes and regulations that require schools of nursing to give academic credit for people who have experiences that relate to potential course objectives and learning outcomes. So there's a lot that we have to do for students, and we're excited to get this toolkit completed. We're well on our way to finishing the toolkit. On the flip side, the practice settings, they have never really had students be employed. Actually in California, the governor has stated that he wants to directly employ these student learners. So they will be hired by the state of California and be on the payroll of the government. And so we don't have to worry so much around the employment component for for practice institutions. The government will cover liability, will cover health insurance. But how do these, given that this is a brand new system, how will practice settings onboard and credential these people to actually work in their institutions? Will assignments be created? What are the roles and responsibilities that the students have so that everybody understands what they should be doing, kind of what Joe was mentioning for the physicians. And then understanding what the institutional minimum requirements are so that we can accurately match the student with the practice setting. And then there's also the education of current staff. Again, how will the charge nurse of a particular unit or a group understand how to create an assignment, how to ensure that the correct roles and responsibilities are met, and what kind of supervision is required. The roles and responsibilities have been articulated. We have formal guidance from our Board of Registered Nursing, which is a board that oversees our licensure. And so we have some clear guidance from them, which is very helpful. In the faculty domain, it's interesting. We've been finding a wide range of responses. We have some faculty and administrators who are see this as an opportunity that is definitely in line with the philosophy of nursing. And then we also have another end of the spectrum, which are very protective of their students. And I must say, in my analysis, it borders on paternalism or maternalism. And so we have to recognize that students are free agents. They have will and agency to make decisions for themselves, and it is our responsibility to tell them what the benefits and risks are. But at the end of the day, it's their life and they want to contribute. And I will declare a bias of my own. I mean, being an emergency nurse and being a Red Cross nurse for over 20 years, I see this as an opportunity. But I also recognize that there are grave concerns for students and faculty's own physical and social health. And to Joe's earlier point, nothing of this is mandatory. But yet, how do we help faculty open doors for students who might want to respond, understanding full well the benefits and risks? What kind of academic credit and institutional policies in the academic institutions need to be addressed and adhered to? And what is the supervision issues around non-affiliated clinicians? Like, again, if somebody was going to school in San Diego, which is in the southern part of our state, and they had to move back home, back in the Oakland or San Francisco area, and wanting to volunteer or be paid and use that experience for clinical credit. There is concern from faculty maybe in the San Diego area that they don't know who the preceptors are in the Oakland area, and that's a valid concern. And yet, at the same time, I believe that any clinician who's responding to COVID-19 will not steer a student wrong or try to trick them into doing something that's inappropriate. We do all function with our own standards of professional ethics, and I believe that it will continue to, I have no reason to believe that it will not continue in a disaster situation. And then the last domain is really the statutory and regulatory issues. Again, we have authorization from our governor and an executive order that our Department of Consumer Affairs, which is the overall agency that oversees all of our boards and bureaus in California, is looking at waivers, and they have a process to ensure that waivers are being received and evaluated by the legal team, and then waivers will be approved as deemed appropriate. So it's part of our role in the practice and setting, really, and in workforce centers to evaluate the statutes and regs to make sure that we have brought the ones that need to be addressed forward so that we can get these students out into the workforce.
Okay, great. Thank you. That was a very comprehensive answer, so appreciate that. So I'm actually going to turn to Joe now. Would just like to follow up in terms of how this is playing out for second and third year medical students whose you know, the third year clinical rotations may have been interrupted, and for second year students, you know, how are schools working to maintain the pipeline for medical students?
That's a really good question. It's really been difficult, to tell you the truth. For third year students right now, a lot of them ended their, you know, they had to stop their rotations while they were maybe almost completed with one and still needing to go into another. For those students, a lot of the schools are offering online opportunities for them. They have the opportunity between now and the end of the year to do some electives that they normally would have done in their fourth year. So the schools are trying to be very flexible about what it is the students can do during, you know, these last few months. The question comes in, what is next year going to look like? And a lot of people are sitting around thinking about that one because no one is really sure. I actually was on a phone call today with some of the dental schools in New York, and you know, they've been told, the school, and I'm sure this is true for their medical school as well, the school that is out at Stony Brook on Long Island has an Army hospital that was set up right on its campus. And so the administration has said no students here until the beginning of the next academic year. So what happens to those students? You can do so much in terms of online or service learning, or some schools do things like narrative medicine that can all be done online. But in terms of direct patient contact, people are still trying to figure out what that's going to look like. In terms of second year students and even first year students, you know, everybody wants to get involved. Nobody wants to be, you know, sitting this out, even if they don't feel comfortable going to a hospital, whether you're a fourth year student or second or third year student. So the students have really done some remarkable things. They've started sort of like a consortium among the medical students in the city schools, trying to raise money for PPE, trying to, you know, get as many people as they possibly can to volunteer, to help on phone lines. The medical students themselves are often working the phones. They are talking to people who've come in for tests, giving them their test results telling them where they can go if they need treatment, or, you know, what their next steps are in the whole process. So the students have taken a lot of this on themselves. There have been, you know, students who have volunteered to walk people's dogs or to babysit or, you know, do that sort of thing, just so that, because they know that the strain on the people who are working in the hospital is absolutely immense. So everyone is getting involved in their own way, looking forward to, you know, being able to help out. You know, we had, one of the medical school deans was talking, and she said, you know, when she came up through the medical education experience, it was in the time of AIDS, and everyone was just sort of thrown in to, you know, the pot, and here we've got this epidemic going on. We don't know what it is, but, you know, gee, you're a newly minted medical school graduate. Go help out here, you know. And it was like, she said it was like, all right, we're doing something. We're involved. We're trying to help, you know, this scourge that's going on. And this is what we're training for, you know. And I think that that is really the bottom line with all of our medical students. This is what we're training for. This is what we said we wanted to do with our lives. And so they're more than eager to help out in any way that they can.
Okay, great. Thank you for that. And that I know we're kind of running short on time here. So I did have one final question, and it kind of relates to that about, you know, these are really unprecedented times for students, new graduates. I mean, really all health workers, those of us who have, you know, been out there for several years or more. You know, this is really an unprecedented situation. And so I just wanted to ask if you are, both of you, you know, what nursing schools are doing to prepare these students and new graduates, or, you know, what sort of resources in terms of the, you know, emotional, mental toll that this may have on them, if you're familiar with anything in that setting.
Okay, so, you know, actually a big issue in medical education these days is the mental health of students. There have been lots of examples of students and residents who have committed suicide, who can't stand the pressure of going to medical school. So almost every single one of our medical schools here in New York has a wellness center or a wellness curriculum where they have the students come in and they teach them strategies, whether it's meditation, yoga, going for a run, you know, something to help ease some of the stress. And those centers are still up and running, and they're open to students at all times, and they're open to the students who then go and work in the hospitals. Some of the hospitals and some of the medical schools are providing via telemedicine the ability for students to hook up with a psychiatrist or a social worker. So the structure that they had in place prior to this is still in use, it's still there, and they really do urge the students to make use of it and to see that it is not something that's going to go against them on their record going forward, which has always been one of the big issues with students going to look for some kind of mental health support.
I agree with Joe. A lot of our academic institutions already have a wellness program in place that can be accessed. As we continue to move forward, though, because we've heard of some academic institutions suspending their programs because of the challenges that COVID-19 has in terms of accessing appropriate clinical rotations. One of the things that California does pretty well is respond to disasters and address the emotional and mental health needs. And so as we continue to move forward, I have heard that the government is building this process into the disaster response. You know, we have a lot of earthquakes and fires, and so even though this is a different disaster, we are still prepared to respond to the mental health needs of responders. So it will be worked in and created, but we already have components of that in place just because of our long history with disaster response.
Okay, good. Um, I think that concludes our session for today. I did want to note, I know Garrett, you had some resources, and we will share those on our website as well. And this will be posted as well as some additional resources later today on our Mullen Institute website. Again, thank you, Garrett and Joe, for taking the time and joining us today and giving us your input on these very important issues. So thank you again.
Thank you. It was a pleasure.
Thank you.